Hello, everyone. My name is Mike. I'm a physical therapist and your host of the Health Me podcast. Thanks for tuning in, and remember to leave a like and subscribe so you don't miss any updates. Our discussion this week brings us behind the scenes into the world of prosthetics and orthotics. And for those who may not know what those things are, prosthetics are devices designed to replace missing limbs, while orthotics are devices that help improve the efficiency of an already existing limb. This practice in healthcare can often be overlooked or missed if having the fortune of never knowing or being someone who has needed such a device. As a result, our guest this week is here to spread awareness during Limb Loss Awareness Month, and hopefully he can educate you on the intricacies of this amazing profession. Our conversation will first highlight the background our guest needed to get into his profession, and how a combination of helping patients and the creative process of building these devices what led him to become a certified prosthetist and certified orthotist. Next, we get into how the goal of a prosthesis and an orthotic device is a constant moving target with tailored assistance through a patient's lifespan. Additionally, we go over how unique some of these projects are with further explanation and strategies to be successful prior to being fitted for an orthotic or prosthetic device. Later, we go into the psychology side of things, discussing what the conversation is like when contemplating optional limb loss and how our guest has been challenged in navigating these very personal situations. Lastly, we cover where the profession is going regarding prosthetics and orthotics and how the future is embedded within multidisciplinary care. Our guest has an amazing story, and I'm excited for all of you to listen to today's episode. As you may already know, timestamps and links for everything will be in the show notes. Here's my conversation with Drew Meyer. Because the field of prosthetics and orthotics may not be, not as well known as other professions, I think today let's just discuss how you became a certified prosthetic and orthotics and basically how you entered the field.
Yeah, absolutely. So it is certainly a mouthful. It's really funny when patients are, they walk into the office and they have no idea, really what we do. And they have a harder time even pronouncing kind of what the title is. But the official title that I have is Certified Prosthetist and Certified Orthotist. So we kind of abbreviate that as CPO. And that's a board certification from the American Board of Certification. So we're ABC CPO. So there's a lot of acronyms flying around there. And then the educational training that I have is a Master's of Science in Prosthetics and Orthotics from Baylor College of Medicine. So then we throw on the MSOP at the end of that. So ABC CPO MSOP is what the business card says. And my background's actually in mechanical engineering. So that's how I kind of got off on the technical side of things. I started off thinking I wanted to get into, planes and trains and automobiles, the typical mechanical engineering kind of world. And I got in to like my junior year and I was just like, man, I hate this. This is terrible. This is just like not what I thought it was going to be. It was tons of computer work, tons of math. Like I like math and I like computers, but I also like working with my hands. And like the modern engineer, it's a lot of desk work. And I actually had an elective class in my junior year that was called Introduction to Biomedical Engineering. And I was like, oh, this is really cool. This is something I can get behind. Ended up adding a minor in bioengineering and kind of went down the bioengineering route. So my first couple jobs out of school were medical device design. And interesting looking back, it was actually kind of like 3D printed prosthetics at the time, but it was custom made surgical cutting guides for surgeons who are doing like craniofacial reconstructions and stuff like that. And then we would also, custom 3D print metal implants. So if someone had like a massive facial trauma and needed like a reconstruction, we would make these from like a CAT scan, these 3D designed and 3D printed implants. But at the end of the day, for me, it was more of a manufacturing job. It wasn't really like I didn't get it wasn't a patient care job, right? I didn't get to see the patient. It was all anonymized data sets that we were working with. I never got to see the outcomes. I didn't get to interact with the family or anything like that. And so for me, it was just a manufacturing job. And I just went nuts sitting at a desk all day. So I actually got laid off from this like startup I was working at. They basically like ran out of cash, and they like called an all hands meeting and just like laid everybody off in one swoop. And that was like 8 days before I got married. And so it was kind of like, oh, all right, well, change of plans. But my wife was super gracious and like, gave me the opportunity to just do some soul searching and find out, what do I really want to do? And there was this random happenstance event where I was doing a favor for someone, and it was like a friend of a friend, like needed a ride to dialysis. And so I was like, oh, I'm not doing anything. I'm unemployed. So this took this guy to the hospital, took him to a dialysis appointment, and I was going up the elevator, and there was a guy that had a shirt on that said Hanger Clinic. I don't know if you're familiar with them. They're a big O&P provider group. And I was like, I think I saw that name when I was job hunting. So I started hitting the guy up. I'm like, I'm in job hunt network mode at this point, right? And I see this guy and I'm like, well, maybe he can get me a job. Well, long story short, he handed me a business card of the Colorado residency director. And I went and shadowed this guy who was another practitioner, CPO. And I'll never forget it. I went and shadowed him for like 4 hours, like a half day. And I saw him fit like a baby cranial remolding helmet. And then the next patient was like some middle-aged lady that needed like a back brace because she had a lumbar fracture. And then the next guy that came in was some 75-year-old above the knee amputee who was getting a new prosthesis, and it was like a check socket fitting. And so the guy walks in on this prosthetic device, pops it off, hands it to the practitioner I'm shadowing. And I was just like, whoa, that was weird. Like, I didn't know that was a thing. And then we walk into the back, and the guy has this whole workshop in the back, and he takes out like a blowtorch and a grinder and starts like modifying this prosthesis. And I'm like, this is a job, you can get paid, this is awesome. And I was like, four hours of shadowing, and I was sold. And I was like, this is done, I want to do this. So I went home and I Googled, what does it take to be a prosthetic person? And it turns out I was like, dang, I got to go back to grad school, get my master's. And so I Googled, okay, where's the closest program? And it's like, I'm in Denver, and it was either Chicago, Dallas, or like California. And I was like, well, nothing's close by. Cool. So, I applied to programs, did the usual thing, and then got into the program at Baylor, which was cool because it was actually a brand new program. When I went there, I was the second class to go through. And that was neat because it was just, lots of new energy, new facilities, just kind of the way that they set up the program was a little newer and a little bit more modern thinking, so everybody was issued iPads. It was all digital curriculum and stuff like that. And, I'm thankful for that opportunity. And plus it was an accelerated program. So normally the training is a 2-year traditional schooling grad school, or traditional school calendar is what I meant, 2-year grad program. And then you kind of graduate and you're off on your own to go find a residency. And it's usually 1 year for each orthotics and then prosthetics. So total, it's about a 4-year process. But the way that the traditional model works, it's 2 years of school, and then there's usually some sort of a gap. And then you finish your first residency program, get hired as a certified practitioner in that single discipline, and then hope that you can find somebody who will take you on and train you for that second discipline as well. So that ends up being a 5, 6, 7-year process. And I think people recognize that that was just not ideal. And so then they've changed the program a little bit. Well, at least so the program I went to, and then some of the newer programs are doing more accelerated. So it was a 2.5-year combined everything, residency plus schooling plus everything. So it was like drinking from a fire hose, 8 to 5 school straight for a year, no breaks basically. And then it was a combined residency. So I did orthotics and prosthetics at the same time for a 1.5 years. And here we are, man, 6, 7 years later. and all of a sudden I'm dual certified prosthetics and orthotics, and running my own gig here in the mountains outside of Vail.
So what you're saying is, you know what you're saying. You know what you're doing.
Well, I've seen one or two things, not a 30-year veteran, but been around the block once or twice now.
Well, for those who may not understand maybe the difference, or exactly, maybe they're completely new to this idea. I'm trying to imagine there's somebody who's listening to this and they haven't even thought of the idea of a prosthetic or even an orthotic in their life. And so can we maybe define exactly what a prosthetic and an orthotic is, and then just describe briefly what the differences are between the two?
Yeah, absolutely. It's it's interesting because I think a lot of my classmates, and this is true of my story to some extent, is a lot of people get into the field because of prosthetics. People know about prosthetics maybe a little bit more than they do about the world of orthotics. The world of orthotics is a little bit more obscure and maybe not as cool or glitzy or sexy or whatever it is. A lot of people are like, oh yeah, a prosthetic device is inherently neat because it's somebody who has suffered limb loss of some sort, whether it's a toe or a partial finger, part of a hand, a full hand, upper arm, through the shoulder, below the knee, above the knee, through the hip, whatever the different level of amputation is. We would technically be exoprosthetics, so it's external, not internal prosthetic devices, and it's for extremity limb loss, right? So the most common examples would be partial foot or below the knee, and then partial hand or below the elbow. In general, prosthetic care is majority lower limb, so like 80% of all amputees would be lower extremity related injury or disease process. And then of that, 50% of those would be related to some sort of a vascular or neuropathic condition. So diabetes, peripheral vascular disease, some sort of a neuropathy condition. So half of all lower extremity amputees had a neuropathic or vascular etiology. And then if it's an upper extremity, a lot of times it's either congenital, cancer, or traumatic. And so a lot of those are workplace accidents. And then on the orthotic side of things, that would be it's an orthopedic brace of a variety. And what's fun about both orthotics and prosthetics, but really more true in orthotics, is, there's a wide age range. So like just last week, I saw a 1-year-old and then I saw a 94-year-old. And so we see the whole spectrum because there's a wide need of why people need an orthopedic brace. And our specialty is really custom made orthopedic braces. Again, primarily foot and ankle is the biggest concern, lower extremity, knees, foot and ankle, and stuff like that. But we also do spine, cranial, upper extremity, and, again, lower extremity. So those orthopedic braces are broken out into kind of how tall or how long the brace is, how many body segments, how many major joints does it cross. So a simple example would be like a foot orthotic, right? So that's what most people think of when they hear orthotics, is custom-made foot orthotics. Colloquially, we call those orthotics. But, for example, for kids, there's like the little SMO, supramalleolar orthosis, so it just goes above the ankle bone.
Yeah. For those who are just listening, he's holding up like a small little brace that basically almost looks like it would go around the heel, and it's got some straps.
Right. Good point. Thanks. And, really common for Down syndrome, low tone, hypertonia kids. And then, for somebody, for example, who had like a stroke and now has an extensor pattern, and maybe it's flaccid, maybe it's spastic, maybe it's some other neuro condition, they're going to need a much stiffer AFO, so ankle foot orthosis, something that goes across the foot, the ankle joint, and then almost up to the knee. And then like that polio patient that we were talking about earlier, a lot of times they have severe leg weakness and severe knee instability and deformity. And so all of a sudden they're getting a long leg brace all the way up to the hip. And like Forrest Gump is, so the example I always tell people, if it's like, if I got 10 seconds to tell them what I do, I say Lieutenant Dan and Forrest Gump, because Lieutenant Dan had the below the knee amputation, and or actually, sorry, he was above the knee, and then Forrest Gump had the long leg metal braces and stuff like that. So that's kind of the quick rundown.
And he's covering multiple different areas. And if you're listening, you're not understanding some like the spasticity, the tone, the flaccid, or just like even like understanding some of these impairments that he's discussing. It's multifactorial. There's many different conditions in which a prosthetic or an orthotic will come into play, and also there's a lot of overlap between the two. So not always somebody will need a prosthetic. Sometimes they need an orthotic, and there's a lot of give and play, I can imagine, between using them and problem solving, like what is going to be the best for the patient. And I'm assuming there has to be a significant amount of effort that goes into making these completely individualized for humans, because we're all so different, so unique, and we move in a certain way. And I suppose, what is the effort that goes into making each of these? And is there different, like maybe time wise, is there a significant difference between orthotics and prosthetics? Are they the same? And it is the thought process just really long and thinking about how can I make this as tailored to the patient as possible?
Yeah, absolutely. It's really dependent on the presentation of the patient. So what do they show up when they walk or roll into the clinic? How bad is their injury? How long ago was their injury? What is their disease process that they may be suffering from? And again, how chronic is this condition? And that will depend on a lot of different things. So again, we end up seeing quite a variety of neuromuscular conditions and musculoskeletal conditions. So that's kind of like our little world that we're familiar with. And I guess there is quite a lot of work that goes into the fabrication of these devices, but it's really this huge process, because we see a patient, usually we have a prescription from a physician saying evaluate and treat for lower limb orthotic or below the knee prosthetic care or something like that. And so it's usually a really general ordering prescription that just says, hey, this patient has a problem, and most physicians will just depend on a local O&P practice to just figure it out. So they send a patient over and they trust us to just say, we usually put together some sort of a recommendation, a report that says, I saw Mrs. Jones today. It's a little bit like an initial eval for a PT, I'd imagine, where we're checking, we're doing an observational gait, maybe an instrumented gait analysis if we have it. Definitely observational gait. We're not as neurotic about measuring the degrees with the goniometers and stuff like that, but most of us are going to be doing range of motion, manual muscle testing, and more and more, we're late to the outcome measures game. So we're figuring out like how to use those and what that looks like. But we're usually doing some sort of an evaluation of saying, okay, this is what the patient presents with today. Have they had any previous devices of any sort, or is this the first time? Is this a new injury, old injury? And then after we kind of put together a recommendation, we send something back to the doctor saying, hey, this is the device that I recommend. Have them sign off on it. We usually have to submit that to the insurance. Then we play the stupid insurance games for months and months about getting these things approved, because there is a lot of work going into them. They can be rather expensive. And as it is in the prosthetics world, we have to order lots of components. And so whether it's a foot module that is sized to the patient and spec'd out to their weight and activity level, different adapters and components that can give us the correct alignment that we need. If they're an above the knee amputee, then there's going to be some sort of a knee joint And then there's the socket interface. So like, I'll just show you an example of like, so it's like the what they stick their residual leg into, and then we connect the foot and the to the base of the socket.
So maybe just describe what you're holding there.
Yeah, absolutely. So it's a people don't like calling it this, but for lack of a better term, it's a little bit of a bucket, right? And so people stick their leg into it. There's usually some sort of a locking mechanism that will mate to a gel liner that they rolled onto their residual leg. And now all of a sudden they are locked into this prosthetic device so it doesn't fall off. Well, we have to make that somehow, and it usually involves a bunch of measurements, taking a hand cast of the patient's leg, usually under some sort of pressure so that we're deforming the soft tissues, capturing the actual shape of the underlying skeleton, whatever is left, whatever shape that the tibia and fibula are in after there's an amputation below the knee, for example. We have to take, when the foot goes missing, we have to put that pressure somewhere. They have to be weight bearing, and nobody will tolerate weight on the cut end of the bone. So we have to put that weight somewhere. That pressure has to go somewhere. So we do that during the kind of second, if the initial evaluation is like the first step, and we have all the insurance approvals and stuff like that, then the second step would be a casting appointment. And if it's an orthotic device that we're trying to make, that means the person has a limb. That limb is intact, but it is not functional for whatever reason. They're either in pain, they have instability, or weakness is the most common stuff. So for example, a stroke patient, they're going to have weakness and they're going to have instability over time. And over time, that weakness and instability leads to like chronic ankle sprains or chronic drop foot, and situations where they are hurting their ankle, they're in pain, and they need, they've tried some sort of brace that they bought at Walmart. They got something from their ortho doc in clinic. They've used it for 5, 10, 15 years. And then all of a sudden, hey, I'm still in pain. That's usually when people show up in our office and they say, look, I've had this brace, I've had this condition for 15 years. I've had this off the shelf brace. It doesn't fit me anymore. It doesn't work anymore. For whatever reason, I'm still in pain. And then we say, okay, you need this custom brace. This will help you more. This will help you get some of your mobility back. This will help reduce some of your pain. So to make that, I will cast them not in their deformed, unstable position, but we will try to position the foot and ankle into the position of most functionality, of most stability, of reduced pain, whatever that ideal position is. We'll position them in that ideal position, and then take a cast of their leg or extremity or whatever body part it is we're dealing with in the most ideal position. Let the cast harden, take the cast off, and now we have a negative model of their limb or anatomy in the most ideal position. True for a prosthetic device too, but now we're getting the shape capture of their limb under the ideal loading conditions or the ideal kind of alignment and positioning. And so now we have a negative cast model of their anatomy. And we have to turn that into a functional brace or artificial limb. And that fabrication process, I mean, man, we could go on for hours about that. So I'll save you all the gory details, but there's lots of materials, different thicknesses, composites, thermoplastics. The way that we fabricate those things, we're always trying to go for strong, reliable, and lightweight, as low profile as possible. People are always asking us, to make it not bulky. And I'm like, well, it's got to be bulky enough to do what we need it to do.
Yeah.
And so it's, it is hard sometimes saying, well, this has to be big enough to hold you up, and I don't want it to crack and have you fall down and get injured and then sue me. That's a bad day. So there's a variety of materials. Usually we're using some sort of plastic or a carbon fiber composite. And to do that, we usually have some sort of a workshop. Bigger offices usually have trained technicians who are fabricating these devices or helping us fabricate those. And then really big offices will have assistants as well who are helping to fit or adjust these devices. So a lot of times there will be a practitioner doing an eval, a casting, pass it off to a technician to fabricate it. An assistant will help fit it. The practitioner will come back around and certify the fit of it. And then, one of the unique things about this field is these are long-term relationships. An amputation is for life. And we are seeing these folks for 10, 15, 20 years. So long-term relationships, which is one of the things I really like about the field. Or if it's like a progressive neurological or orthopedic condition, like MS, this condition is not going away and they might be getting weaker. So they start off with a small brace and then they come back in a couple of years and need a bigger brace. And so a lot of times we'll track these patients for years. Or if it's a kiddo with like cerebral palsy, for example, we're making them a tiny little brace when they're a tiny little, 1 or 2 year old. And then we'll see these guys for 10, 15, 20 years as they grow up and help them try to maintain the best posture and joint alignment as they grow. And that's one of the fun things for me is those long-term relationships and seeing somebody, roll into the clinic and walk out or somebody limping in pain and then they walk out confidently. And, that's what does it for us. That's what we love to see is those outcomes.
And it's certainly, there's so many different moving parts. You're describing how over the lifetime, somebody who's younger, their body's going to change. And even someone who's older who has something such as MS, they're going to get weaker. And so there always has to be micro adjustments. There's things that are constantly changing in order for the patient to continue doing the things that they want to do and make sure that they're not causing any harm to if they have the amputation, doing more damage to their limb, or making sure that they're not, doing any more damage to their body if they do have an orthotic. Now, when you are creating a prosthetic or an even orthotic and you're doing your evaluation, how are you basing it off of like an ideal? Because if they don't, are you using the other limb to compare sides and to reference to? Because you didn't really know what they walk like beforehand.
Right.
With a prosthetic. So say that we're just dealing with a below the knee amputation, or even somebody who's got drop foot, we don't really know what they walk. You don't really know what they walk like beforehand. How are you trying to normalize their gait to like a normal?
Yeah, good question. In a big way, we have to be gait experts. So we're very familiar with the cycles of gait and the phases of gait. And so
And gait
on
is
one
walking,
level,
by the way. Sorry.
yeah,
People always hear gait and they're like, what the heck are you talking about? And it's like, it's
talking
walking.
about, yeah, right. And that's absolutely one of the most fundamental things that we do is understand what normal average human walking looks like. And so we're always referencing just normal human locomotion as a base data set for anything that we compare to when we see somebody with a condition or a pathology that comes in. So one big thing is we will always reference, the average normal human values for gait and locomotion. When the patient comes in, it, like absolutely, if they have a one-sided amputation, we're going to compare the alignment, the position, the shape, the height, the length of the foot on the sound side, on their remaining good side. And so in an ideal world, that remaining extremity is intact and unaffected, but a lot of people who have an injury, that remaining side is also affected. So maybe somebody had an amputation from a car accident, and so one leg was totally broken into, hundreds of pieces, but the other side also suffered multiple large fractures and had some deformity or some residual nerve damage, and they might have drop foot on the remaining sound side. It's not really sound. And so it can be really challenging to say what is normal, quote unquote, for this patient. If they've had a progressive neurological disease. And so, 15 years ago, they were walking, quote, normal. And for the last 15 years, they've had weakness, instability, and pain. they're going to be walking very differently. They're going to be lurching. They're going to be stumbling or limping, taking, really abnormal step lengths or lots of trunk sway or whatever it is. And so to fabricate a prosthetic device, we're taking measurements from the sound side in terms of height and lengths and weight measurements and stuff like that. But in terms of setting up either an orthotic device or a prosthetic device for maximum functionality, we're going to be trying to get them back to whatever looks and feels normal. And that's a moving target sometimes, especially for an amputee patient, because getting a new amputee to stand is a big deal. And then to get them to take short steps, and then to get them to take bigger steps, and then to get an equal reciprocating gait with equal step length, and to get away from the parallel bars and the assistive devices, and to get them back to walking around in the community, and then to go onto variable terrain at variable walking speeds. There is a huge rehab curve there. And that's the beauty of, like, when we get linked up with a good physical therapist, right? Is that's usually how we make those transitions, is we make the device, we get the person fitted and trained, get them kind of dangerous enough to start the rehab in a big way with the therapist, but then we 100% depend on good PTs for gait training and fall training and the neuromuscular reeducation of whatever the condition is, whether it's an amputation or a condition that needs a brace. We're very linked in with good PTs who like to take on amputee patients, for example. And it's rare to find the ones who are like psyched to work with amputees and know a lot about it, because it's like a lot of people are like, yeah, I would love to work with an amputee, but I haven't really seen a lot of them. And so it makes for an interesting world where, when we call up a PT and say, hey, I got, Mrs. Jones just got her prosthesis, do you think you could pick her up for some gait training? To have those conversations is just invaluable.
Yeah, and also it's a difficult time in a patient's life, as well as, for the therapist, it can be definitely overwhelming, because you kind of briefly overlaid how quickly, or like the many stages in which somebody has to basically learn how to walk again. And you're not seeing this patient for a short period of time. This isn't happening in the matter of like, okay, then you're gonna stand, and then you're gonna take short steps in like next week, and then you're gonna take long steps, and then you're gonna be running in like 2 months. Like, it's like, this is a long process to get you from point A to point B. And you need to make sure for every step of the way that, as a physical therapist, you understand like how to make adjustments with your prosthetist, and making sure that you're collaborating to understand what you need to do to make better. Because again, you're just going off from what you think is going to make the patient ideal in regards to walking. And they may be walking and it may be hurting their low back. And so we have to make an adjustment in that way when they actually start walking. And then throughout that process, okay, now walking feels okay. But then when they hike, or perhaps even if they're just getting out of the chair, they're having an issue with getting out of the chair. And it's like, okay, maybe you have to adjust I'm assuming the length of the limb or whatever. And so there is this constant communication between therapist, prosthetist, patient, and so on. And are you collaborating with a lot of physical therapists? I'm assuming that's what you do as well. And have you seen the realm of just collaboration and multidisciplinary care grow within this realm, or is it just a continued process that you're trying to build out from?
Yeah, good question. I wish there was more crossover and interdisciplinary environments, but a lot of this stuff is really siloed these days. You have these really established PT therapy clinics, you have these really established O&P clinics, and then you have the established ortho and outpatient and inpatient stuff. And in a big way, they're their own systems and they don't talk to each other very well. I think that just sums up modern healthcare, unfortunately, in a big way. There's all these electronic health record systems, and they just often don't talk to each other. So like, we have an O&P specific, electronic medical record system, and sometimes I'll print things out fax it over to somebody, they'll print it and scan it into their thing or whatever it is. And it's just like, it's insane that we're still depending on that, but that's a whole nother soapbox for another day. But it leads to some breakdown in communication, where I just say, okay, go find a physical therapist now and hope that you find somebody really good who knows what they're talking about. And, or, the other side of that is a PT just says, well, you should probably get a brace. Good luck finding one. Right. And that's like where it's so great to just be friends with the PT so that we can just text each other and just say, hey, what would you think about a recommendation for Mrs. Jones, blah, 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 blah. And that is like an essential thing that took me multiple years to kind of forge those relationships. But even better than that is really what I would call the amputee clinic. And it's usually a physiatrist, so a physical medicine and rehabilitation doctor is the examples that I've seen that work really well is you have a physiatrist who hosts an amputee clinic, and they are overseeing the long-term care of many amputees. And they are also seeing them inpatient and outpatient. So if somebody had an amputation and they are in the hospital, the physiatrist will round on them, see them early in their rehab care. I call them like the quarterbacks in a lot of ways, because they will get the inpatient therapy involved. They will have a prosthetic consult to do some sort of a limb protector device, and just the initial prosthetic consultation of just saying, hey, you are now an amputee. What does that look like? People always have questions. We get to show them devices. We often bring in a peer mentor. So another patient who's an amputee who went through a similar condition and is now out in the community thriving, we will bring in folks like that to talk to patients who are just recently injured. And then, the patient gets discharged from the hospital, comes back to the outpatient amputee clinic, sees the outpatient physical therapist, usually sees a caseworker, some sort of social worker, something like that. Maybe there's OT involved. But the most basic clinic that I've seen is you have physiatry, therapy, and the prosthetist is like the most fundamental. And then everybody's on the same page. They are all saying, okay, therapy, do this, prosthetist, do this, circle back with the physiatrist in 3 months, go. And everybody's on the same page. Patient didn't have to go to 3 separate appointments. And then all the 3 providers didn't have to all talk to each other individually, because that never happens anyways. So an amputee clinic, multidisciplinary clinic, is really ideal for these patients. And then a lot of times they will host a separate bracing clinic. So for all the orthotic patient needs that need new braces or have never had a brace and need a brace, it'll be the same environment. It'll be an orthotist, a therapist, and then a physiatrist. And those are really ideal. In Denver, there's 2 clinics like that. And in Houston, where I did my training, I think I knew of one. I mean, Houston's a huge city, and there was like one. So they're not common, but they are awesome when they work really well.
Which is good for people to know, because sometimes people don't understand what good looks like, right? Like perhaps they're not near a big city and they're in the middle of Kansas, and they're like, yeah. I went to the doctor and they told me to get an orthotic, but there's not an orthotist or a prosthetist or, whatever your issue may be, for miles and miles. And so at least if people kind of have an idea of what it should look like, they can go searching, or at least call a clinic somewhere else and be like, hey, what should I do in this scenario? And if you are somebody who's listening and you have a family member, or you are somebody who needs a prosthetic or an orthotic, it's important that you try to find people who are working very closely with these patients a lot, because again, not a lot of people do specialize in this area, unfortunately. And obviously that continues to grow, but make sure you're being your own advocate as a patient or a family member of a patient.
Absolutely.
And before, when someone comes into the clinic, perhaps maybe they just had their surgery, they just had they had a limb removed, or um, perhaps they need an orthotic. Is there preparation that someone should do to put themselves in the best position to get fitted for a device? Should they, similar to other surgery, should people try to get really, really fit? Should they try to lose weight? Should they try to be as fit as they can before a surgery like that? So that way, when they get out of the surgery, when they come to see you as for an orthotist or get fitted for something, that they're pretty much as ideal as they can be.
I mean, of course, the answer is always yes. It's a weird world though, because if it's an orthotic patient, usually they have some sort of a degenerative or progressive disease, and so getting fit when you have MS is a weird thing to define, right? It's like as fit as possible, sure. As limber as possible, absolutely. I think that's probably the more common thing is range of motion limitations, because they can't strengthen these muscles that are weak and diseased. And so it's like, okay, well, try to remain contracture free, meaning don't have any range of motion limitations. That's probably one of the most fundamental things that I'm telling 92% of people that I work with, whether it's an amputee patient or a brace patient. Because if they have an amputated limb, say it's a below the knee amputation, the knee is the next major joint, and that is the one that's most likely to be affected, whether it's by arthritis from overuse or misuse, or suffering from contractures because they're not strengthening and stretching the knee joint. And so that's where, like, there's this nonprofit organization called the Amputee Coalition. They've put together a lot of really good resources. And so I'll always send new patients to the Amputee Coalition website. And they have all these resources about strengthening programs and things like that, but they're geared towards amputees. So here's how you do these adaptive strengthening exercises. Here's how you do these adaptive stretching exercises. And just so people can see those things, and there's usually some really good YouTube videos about it with other amputees, so they can say, oh, that's how I can stretch at home. Great, awesome. The best case scenario is when someone has formal prehab with a therapist. And so if in the rare case that they know they're going to be having an amputation surgery, in like a limb salvage scenario, for example, when somebody has a major traumatic episode, a crush injury, high energy fall or something like that, and really does some damage to the foot and ankle complex or the lower leg, and they've tried multiple reconstructive surgeries, it's ideal to get those people as fit as possible, but a lot of times they're in so much pain, it's just really difficult to do any exercise. And that's why they then go on to amputation, is to get a better quality of life. And I tell you, that has got to be the most bizarre thing that school did not prepare me for, is the pre-amputation consult is like the weirdest conversation to have with someone, because this person might be a brace patient. They have a mangled lower extremity. They're in a ton of pain. We've tried to make them a brace to help them with that pain. And it's kind of working, but it's kind of not working, and they're still in pain. And now this has dragged on for 2, 3, 4, 5, 10 years. And the person is still in pain, and they've had another reconstructive surgery, and now the hardware is infected. And now they're not ambulatory for the 10th time in 3 years. They're non-weight bearing again. And they're just like, man, I want my life back. Doc, just cut my leg off. And people get to that point, and it's a surprisingly, I mean, it's not common, but in the role that I'm in, it's common. And happening weekly, monthly, definitely. And I have, we have these conversations where we're saying, you are not an amputee, you're considering electively becoming an amputee. What does that mean? And okay, what can we do now to make you successful? What can we do to prepare you for future success? And having that conversation and walking somebody through that process and getting them linked up with a really good therapist on the front end to get them through this journey as effectively as possible. It's a really bizarre journey, but it's also like amazing when they come out the other side, elect for an amputation, and then get their quality of life back because they're not in pain anymore and they're able to go walk the dog, and they haven't been able to walk the dog for 6 years. You know, that is where like the psychology of disability really comes into play here, because you know we do work with a lot of people with really long-term physical disabilities, and oftentimes they're not getting better, and so we have to say, okay, what is the best possible outcome here? And that's a moving target in a rehab scenario for sure.
But that's such a unique position for you to be in, because for me, I'm just changing my exercise program. But in that scenario, you're like, well, the definition of quality of life is, like you said, a moving target. And so if their quality of life is like losing a limb, to somebody else, that might not be the quality of life that they want. But
Right.
for you, you're like, well, you can either continue this path and we can maybe try another therapist. Maybe we can try talking to a pain medicine management doctor, or we can cut off your limb
Yeah.
and move forward with whatever comes next. And has that role been probably, it has to be one of the more challenging aspects of your career? And have you had to work on maybe just being able to explain that and emotionally handle that scenario? Because again, I'm thinking about it right now and just like, well, we have plan A and plan B, and it's like we can rip off your leg or we can continue the plan that we're on right now. So it's got to be, you
Right.
have to handle that with grace is what I'm asking.
Yeah. It's something that really took me by surprise when I first started practicing on my own, is to have those conversations and to have a positive outcome from the conversation, right? And to not just leave people more confused and frustrated. Um, yeah, it is a weird series of conversations, and it's not always one event. You know, sometimes it's multiple questions over multiple months or years even, but oftentimes it is one big, you know, the family member's there, the suffering patient is there, they had just spoken to their doctor, and now they say, okay, Drew, what do you think? And you know, very rarely have I said, yes, cut that thing off. I think I've only said that like twice. Because nobody wants to be the person that is responsible for that, right? And so it's very rare circumstances that I'm like, yeah, 100% just lop that thing off and you're going to be way better off. Most of the times I'm actually thinking that, but I'm not going to say that because that's not what the people need in that moment. That's actually where the peer mentor really comes into play, is a lot of times somebody who's gone through this before. I can't tell you how many times we've brought a peer mentor into the room. So somebody who is an amputee using a prosthetic device walks into the room with jeans on. The patient who's getting the consult doesn't realize that the guy that just walked in is an amputee. They start talking, and then the peer mentor rolls up the jeans and shows them the prosthetic device, and the patient goes, "What?"
Mm-hmm.
And all of a sudden they go, "There's hope. If I get an amputation, it's not the end of my life. If I have to have a prosthetic device, I can walk the dog." That's amazing, and to see the hope that actually comes around. It's a really weird series of events that leads to that circumstance, but in that moment, that's actually very hopeful for people, and to see that maybe there's a way out of this suffering that I'm in right now. I mean, it's not going to be a perfect scenario because life with an amputation is permanent and not problem free, but it's trading a set of problems that really doesn't have a solution for a set of problems that maybe has a better solution. So yeah, it's very much a grace-filled conversation, and one that is usually rife with tears and lots of emotions. But it's also, to me, one of the most valuable things that I can provide for people with like the weird skill set and knowledge base that I have, is to be able to say, look, I build braces for people and they are successful with these braces, and I build prosthetic legs for people and they are successful with these devices. And, based on what I'm seeing here, this brace isn't working for you for these reasons. I think you would actually be successful with a prosthetic device. And then it's up to the patient to decide, what they want to do. But I'll tell you, one of the interesting things is, this is by no means a knock on therapists. Therapists are always like, man, we got to get improvement. We got to see gains. We got to get you to the next level. And a lot of these patients have suffered whatever condition or injury that they are not going to see improvements. And so, a lot of therapists that I've interacted with kind of just look at me like, Drew, help me. I'm not getting any gains here. And I'm like, okay, we can build them a brace, but really what they need to do is go back to the orthopedic surgeon and have an amputation consult there and say, what's going to change? And that whole scenario where the therapist has worked with this patient, they're not seeing progression. We've built them a device or two or three, and there's not progression. Those are some really tough scenarios, for sure.
I believe it. And it, as a therapist myself, I can understand that. And I think that can be definitely driven by insurance and making sure that you are seeing improvement and making sure that you are this person who's providing help, because you do want to help people at the end of the day. And I think that's where we're all trying to come from, a good place of like, we're trying to help you. I suppose, what are some other, you kind of highlighted some misconceptions with this idea. Are there other misconceptions that people maybe have about prosthetics, maybe going like prior to getting an amputation or getting an orthotic? Are there perhaps misconceptions that people go into it that you need to kind of address?
The couple of common things that I run into is, it's usually in the hospital after an amputation surgery or injury or some polytrauma episode where they were, tons of injuries or whatever it is. Some well-meaning nurse, and not to knock nurses, my wife's a nurse, but it's usually some well-meaning nurse. Somebody along the way just kind of says, "Oh, don't worry, you'll be up and running in no time." Well, not exactly. And maybe never. Maybe some people don't ever return to that level of functionality. Oftentimes it takes years to get back to running. For sure, we love the stories where it's 6 months later and the person finishes their third marathon. Great. That's like very rare. Most people in a standard amputation scenario, they may not regain their full level of function that they had previously. And so if somebody says, "Oh, no big deal, you'll be up and running in no time," that's like a huge thing. I'm always like, no, that is not true. Like, you have to go through all the hurdles to get there. And I cannot dictate how long it is between each hurdle, but I do know you will have to go through this hurdle, and then you have to go through this hurdle, and then you have to go through this hurdle. And how hard you work and how lucky you are, depending on infection and the nature of your injuries, determines how much time elapses between hurdles. And so some people will progress through those hurdles more quickly and get to a point of community mobility in 6 months. Other people will never regain their community independence, or it may take 5 years. And that's a tricky one. And then the other one is, the biggest thing, especially, I haven't talked a lot about upper extremity amputations. I'm not what I would call an upper extremity expert. There are people who kind of, that's what they do all day, every day, because it is a whole nother can of worms. But like, there's all these robot hands and cool cyborg things. And the most common misconception I get with those is they are not powered by your nerves, and people cannot feel, they're not brain motor machine interfaces. This is like a really rough, if you think about, the hand has 27 degrees of freedom. So all these different joints, and they can extend or flex and do all these different motions in the hand. Well, to control 27 degrees of freedom, you need 27 different signal inputs. Well, we don't have that technology yet. People are working really furiously in the research academic space to make that, where we can have a brain machine interface where you think and you have all these different neural pathways, and now they can control all the different motions of the hand, not to mention the wrist and the elbow and all the different degrees of freedom that come with that. But like the best case scenario for a below the elbow amputation, when somebody is missing their hand, there's a flexor muscle group and there's an extensor muscle group that's left behind. And so at the worst case scenario, you have an on and an off, and those are the two signals that we can measure. So you got 2 degrees of freedom to control. If somebody is cognitively with it and able to figure it out, they might be able to do a co-contract. And so now you can get 4 signals out of it. And with some newer technology called pattern recognition, now we can maybe interpolate between those 4 signals and all of a sudden make it 16 kind of messy signals. Okay, well, yeah, maybe now we can do some fancy things with algorithms and machine control. But the fundamental problem is there are not enough signal outputs from an amputated limb, given our current prosthetic interfaces, to control a robotic hand the way Luke Skywalker controls his, right?
Yeah.
And that's the biggest thing, is there is no proprioception, there is no sense of touch, there is no haptic feedback is like a new thing where you can feel resistance to the object that is being grabbed. Proportional control is really hard. The reason we still use those split hooks, like, people always are like, I can't, but like, I remember when I got into the field, I'm like, how are we still using these hooks from the 60s? And it's because they're lightweight, they're super strong, and they're really low profile. If somebody's going to grab something like, I got my, like this toothpick here. If somebody's trying to grab this toothpick with a robotic hand that they cannot see through, they have to position themselves to the side and then kind of sneak up on it to grab it, right? A split hook, they can see right through it. It's super lightweight. It has a really fine point grabbing thing, and they can grab it just like that. But yeah, it blows my mind that we're still using the split hook design, but it's because it works. And the robotic hands, as cool as they are, they're heavy, they're wicked expensive. They are not waterproof, they are not durable. And so people see these videos of somebody with a robot hand and they're like, yeah, cool. But like in practice, they can do 1 or 2 tasks. And so that's the other misconception, is like upper extremity prosthetics has a really long way to go before they're at the Luke Skywalker hand and arm and stuff like that.
From a society at large, I think, inclusion is something that has, been really important to a lot of people in many different aspects, in many different fields. In the eyes of prosthetists, prosthetics, amputees, orthotics, and so on, how has the view of prosthetics changed maybe over the past several years? And, before people were trying to hide it, or before people were using perhaps, they wanted perhaps if it's a below the knee, they wanted to make it look as similar as what they had before, their ankle, their calf, and everything. But now you see some of these people where they have like these carbon fiber bent things that they use, and people are like, wow, that's super cool. How has that changed over the past few years
Yeah.
in regards to how people view, or at least the public views, prosthetics and orthotics?
Yeah, I think there's been a big shift. And before I logged on today, I was trying to find. I don't know if there's been official research that supports it, but the general anecdotal idea is it's called the Iron Man effect, and whether it was caused directly by the Iron Man movie franchise, I don't think that's one to one, example. I think it was a number of things. You have the war in Iraq and Afghanistan yielded many amputees, and there was newer technology coming around, and there was a lot of news focus on amputees. And you have movies like Iron Man and Bionics and superhero movies and stuff like that, and augmented human capabilities becoming more in the kind of general collective psyche of Americans. And that happening, I mean, think about how long the superhero movie thing has been going on now. I mean, that's just like all the movies these days for the last 20 years have been superhero movies. And somebody like Iron Man with this, bionic suit thing, exoskeletons are a big buzz thing right now. That's just more at the front of the collective consciousness of society. And so for our culture, in a big way, people have started to embrace more and more, instead of hiding my prosthetic device and making it look as anatomical as possible and just kind of not talking about it and pushing it to the side and always wearing pants and never discussing it, because I will get bullied, or because people will think less of me, or because I don't want to be viewed as disabled. That has shifted a lot in a huge way. I think that's shifted to where people are more comfortable wearing shorts and showing off their device. The Amputee Coalition has this thing, like April is actually Limb Loss Awareness Month, right? And so I think it was like 2 years ago, they had like a hashtag called Show Your Metal, but it wasn't METAL, it was like metal, like show what you're made of. I forget how you spell it, MEDDL or whatever. But it was like show it off, like show off what you're made of, but also show your metal, your prosthesis, and show that off as well. So people were showing, hey, I'm strong. Yes, I'm disabled on one hand, but that whole definition has really morphed as well. So people are more likely to show it off. They're more likely to, it used to be cosmetically, the prosthesis had to be skin toned to match the skin tone, and it had to have a foam cover that was shaped like the other leg, which is a whole skill set in and of itself, artistically speaking. Now, a lot of people aren't having foam covers because they get dirty. The skin tone color never matches because our skin is constantly changing with the seasons. So it never matches perfectly. And I think people recognize that over time. Different cultures and different genders are more prone to this. So like Hispanic cultures are going to still be a lot more conservative and like, I don't want to embrace some flashy design. I still want it to look cosmetic. And then obviously females are going to be a little bit more concerned about the cosmesis of a device. But in general, that average has shifted quite a lot to, I'm going to show it off. I'm not going to have a cosmetic cover. I'm actually going to make it look flashy. Like people are putting like LEDs on their leg now and walking around, almost a way of saying, look at this artwork. Look at how special this is. And so now what I hear from patients is the perception has changed from, you're an amputee, or, oh, you're disabled, to, what is that? That's awesome. Tell me more. How cool. Kids are coming up saying, Mom, look at that. And people who, again, I'm not an amputee myself, but, hearing these stories from people, that has really shifted quite a lot. I think we have a little bit of ways to go with braces. People are still like what is this brace thing and why do you have to wear it? But oftentimes I think it's more in the patient's head than it is actually in society. And if they have one bad encounter with society where somebody shames them, they just assume that everybody is that way. But that's a really damaging thing to have happen. So I understand how that could kind of just really have somebody recoil and fear and kind of in shame. But I think that the narrative has shifted a lot.
Overall, is for the profession, where do you feel like it needs to grow the most? And, we've talked about how this has already changed a lot, but are there other areas within the profession that need to change or perhaps are changing right now that you see the most growth in?
Absolutely. I kind of joked about it earlier, but we're late to the outcomes measures game. And so we're still as a field kind of figuring out how to measure and track the improvements of the interventions that we're doing. So giving somebody a leg and seeing them stand and walk, we go, great, mission accomplished. Somebody's walking. Well, okay, how can we optimize their walking? How can we get them that much more functionality, that much more stability, that much more balance? We're still learning, like, okay, how can we measure and track these things? So I think that's one big thing that everybody in the field is trying to push for right now is, okay, how can we document this? And not just for insurance purposes, but like for our own improvements. The other thing would be, our techniques are always improving of how to make these things and our use of new materials and new designs. That's one of the cool things about social media, LinkedIn and Instagram and stuff like that, is to share, hey, I came up with this cool new design or this new approach, and then somebody else sees it and then they build on it. And then we're always kind of taking these ideas and evolving them, which is kind of fun because there's a little bit of an artistic side to what we do. And so people have a cool idea or technique. Sometimes people end up getting them patented, but to get those things patented is so tricky and costly that most people are just kind of like, whatever, I'll make my own little design, open source or whatever it is. And I wish there was more collaboration in the field in that regard. I think some people get pretty campy and want to keep this cool notion or this cool idea to ourselves or just in my little company or circle that I'm in. So I wish there was some more collaboration. But I think the other big thing is just the embracing of digital technology and digital workflow tools. So 3D scanning, 3D printing, 3D digital design softwares and stuff like that. I think more and more of that every day is changing. And so all of a sudden, I have a high powered 3D scanner and a lot of these things are 3D printed and there's some really neat materials, so like this is a flexible inner socket to a hard outer socket that somebody would use. And so this would be, sorry, it's kind of stuck here. Let's see if I can get it out. This is a really neat example though of like what 3D printing is capable of, is making these really unique shapes that just like weren't possible before. Okay, so it's a hollow, flexible inner socket made out of a 3D printed TPU material. And it's crazy how lightweight this thing is. I mean, this would float no problem. I mean, it's insane how lightweight it is, super durable, and it can make these shapes that just weren't possible before. So stuff like this, we're still figuring out, like, okay, what does this mean? How do we use it? And the digital workflow, I think, is really going to change a lot of stuff for us.
Well, certainly very exciting. And for you, there's so many different components that go into this. You've been working with people like this for such a long period of time. Was there a particular project or like a particular patient, or, you obviously name no names or anything like that, but was there a time where you had a particular challenge or a way you had to be really creative that you're proud of and probably the most notable in your career thus far?
During residency, I was at the Shriners Hospital in Galveston, and so they would pick up a lot of Mexico and Central America kiddos who had, various injuries. And they had a burn center there. And so there was this one kid that suffered a really devastating burn injury to his arms and lost both arms through the shoulder joint. And if I recall correctly, one side he had the shoulder girdle, so he had a clavicle and a scapula, but no humerus. And on the other side, it was what's called an interscapulothoracic level amputation. So the scapula, the clavicle were removed as well. So all he had was like the remainder of his thorax. So to see, and it's really, it's really burned in my memory because it's not a common level of amputation. And to see it, like we're used to seeing somebody's head and then shoulders like this, right? But when the humerus and the scapula and the clavicle are gone, all that's left is the ribs. So the ribs are actually, much more, I don't know the correct, words to describe it, but it's not as squared off as of a shape, and it's more of a rounded, and it's smaller, So to see somebody missing their shoulders and their arms, it's a really like, whoa, that just like, that's not something I see every day. So this, just the shape of how this young man looked afterwards was just really startling. And then again, he has no arms, so functionally speaking, he is very dependent on other people. I wish it was more of a prosthetic success story, but it just speaks to the nature of how difficult it is when he has no remaining anatomy for us to leverage, right? So he doesn't have anything left to really move that we can translate into functional motion to power a prosthetic limb, for example. Mm-hmm. Making a device for him was really challenging. I mean, it required months and months of tweaking and work, and we actually ended up getting, the whole goal for somebody like that is just get something to midline so that he could maybe feed himself. That was like the bare minimum goal was, can he grab something, get it to midline? And we were able to do it. It just took so much problem solving to make it happen. But at the end, it was this really interesting, it's called an X-frame kind of design where it grabs the lower ribs and then had this body powered mechanism where his remaining scapular motion could be captured and translated with like a small cable that ran down the prosthetic arm and powered the gripper at the end called the terminal device. And he was able to grab something, flex the elbow, and get it to midline. And that was like, months of us sitting there with the occupational therapist, just trying to say, what about this? What about this? What if we do this? What if we do this? And then the kid only spoke Spanish, and then they'd have a translator. It was this whole thing, but it was a pretty momentous occasion when he was able to get it up to midline and take a bite with it. Unfortunately, he couldn't do much more than that. So somebody still had to prepare the food for him. We're not going to be able to get him to a place where he's totally independent. And so that was hard to see. He couldn't put the device on by himself. Somebody else had to help him put it on. And that was just hard to, see like, okay, there is limitations to what we do.
And certainly it highlights the idea that we've come a long way, but we're still going in a direction that we need to improve upon. And there are people out there who still need our help, and you're on the forefront of that. So it continues to be something that I'm sure that you think about and something that you want to continue building with the other professions. And obviously, like you said, the collaborative practice continues to be really, really important. And that story exemplifies that idea.
Absolutely.
Well, listen, I really appreciate you coming on and sharing so much and being so graceful with everything that we talked about today. We're kind of winding down to the end here with the closing remarks for the podcast. And this is the Health Me to Health You portion of the podcast, where I ask the same 3 questions for all my guests. The first question is, if you had the attention of everyone in the world for 30 seconds, what would you say?
Yeah, fun one to contemplate. I think in the professional sense, I would just really tell people the value of what the orthotist prosthetist brings to the table, because a lot of times we get left out of some of the conversations. And so I would just make a plea to the healthcare world of, hey, involve your local orthotist and prosthetist in these conversations sooner rather than later, because a lot of times we get brought in at the end after the person has had 6 reconstruction surgeries, gone to 6 different therapists, tried all these drugs, had injections, all these things. Okay, we give up. Now go see the orthotist.
Mm-hmm.
That drives me bats. It just drives me bats. I'm like, if we had seen this patient 15 years ago and built them a simple device to prevent the progression of whatever their deformity is, they would not have, they potentially would not have gone down this road. But because of like what you alluded to earlier with insurance stuff, a lot of times that it just doesn't happen for whatever reasons. But I would just say get your local orthotists and prosthetists involved sooner rather than later, even if it's just for a consult. Most places will do free consults, and just to have somebody else put eyes on the patient and make a recommendation, even if it's, hey, they don't need a brace right now, they're doing fine, or what about this brace? Have you considered this? And then the other little thing is, if you're working with an orthotist and prosthetist, the best thing is to have mutual goals. So to say, we're both trying to get the patient to do X, and you approach it from the therapy side and we approach it from the device side. And if we both have the same goals, then much better outcomes. It's when people are trying to achieve different goals and they're not on the same page, and then all of a sudden we're saying different things to the patient. Patient gets confused and neither person gets their outcome, and then everybody loses. So that's the other thing, is to have shared goals, whether it's a range of motion or a functional outcome or whatever it is.
And if you don't have a prosthetist or orthotist that make sure to reach out to one, or at least have somebody that you can reach out to.
100%.
Second question, what book do you recommend, whether a book you're reading now or in the past?
So the most amazing book to me is called Gait Analysis by Jacqueline Perry. And it is this incredible compendium of all the things you need to know about the gait cycle and how people move and normal human locomotion and what normal is. And Dr. Perry just did some incredible research back in the day. She actually, if I recall correctly, she was a physical therapist turned physiatrist, or turned orthopedist. And basically, because nobody ever listened to her as a woman and as a physical therapist in the medical community, they were just like, whatever. And she's like, well, fine, I'm going to become an orthopedic surgeon then. And now people will listen to me. And then she went off and wrote the dictionary on gait.
Wow.
And it is an incredible book, and something that I'm still trying to wrap my head around, but it's just for any therapist or orthotist, prosthetist, it's just a must-have.
Last question, where can people learn more about you and what we talked about today?
So I'm on LinkedIn. I have 3 small kids, so I don't have time for anything other than that. I'm not on the Facebook or the Instagram or anything like that. So I just kind of stick to the professional LinkedIn world. So LinkedIn is kind of where I'm rolling right now. And then email dmeyer@medequiportho.com is kind of another way to get a hold of me.
And again, all links for everything will be in the show notes. So make sure to go down there and check everything out. Drew, thanks so much for coming on the podcast today.
Absolutely. Thanks for having me. Pleasure talking. And it's fun to talk about the nerdy stuff I like to do. So I appreciate you making time for that.
Of course, anytime.